Right, well, why don't we get going? Um, as I explained to our speaker, we're still sort of struggling getting people back in person, but we know that there are many people online. So it's a real pleasure to have Patty Ganz here today to give the Iris Fisher Memorial Lecture. Um, I have known Patty for just a few years or maybe just a few decades. And when I was a young faculty member interested in issues related to quality of life and survivorship, Patty was about the only person doing this. And I think it's fair to say, and I said this at dinner last night, that Patty is really the senior statesperson when it comes to work, particularly in breast cancer, but across malignancies related to survivorship, quality of life, late effects of therapy. And, at a time when I think most medical oncologists and other cancer physicians and researchers were focused on just giving more and sort of pounding away at people, Patty was asking questions about what does that mean for people after the fact, and that is more relevant today than ever before. I will not detail all of the awards that you have won. Patty is a member of the National Academy of Medicine and is just both renowned and beloved in the breast cancer community and the psychosocial oncology community and survivorship community. So, Patty, thank you so much for being here, and it's all yours.
Thanks. And I'm glad that Eric moved the microphone because I'm also vertically challenged a little bit. So it's great to be here today. And I really appreciate the welcome and also the opportunity to share, which I think will be a multiple decade experience. And just to let you know, how my career evolved, but really the focus on symptom science. So just a couple of disclosures here. Okay. So what am I going to be talking about? Well, I'm going to be sharing my journey, and you already heard from Eric about, how I kind of began to work in this area, and I've really been very fortunate. I was really in the early days working on quality of life and symptom measurement in clinical trials, and Lyosh and I were just talking about a trial that I'm analyzing the quality of life for. So I really began in that way when people were trying to say, could we scientifically measure patients' experiences with their treatment and disease. Then I want to talk about my interaction between my own research and what I learned from assessing quality of life outcomes in clinical trials and how I then began to bring that back to my own research. And then lastly, to talk about advancing the whole field of symptom science in cancer survivors and really the need for collaborative team science. And I think that's really what cancer centers are about, is to try and do that kind of translational work. So this was about 1990, and this was a conceptual model that was put forth in terms of talking about quality of life. And there had already been a lot of social science research trying to measure the health and well-being of the general population that came out of the Johnson administration, the war on poverty, a lot of things that were done. How can we measure well-being? And that was then beginning to be adapted to applying it to health and health well-being and health-related quality of life. And cancer, of course, because of the toxicity of our treatments, was the poster child for trying to be able to look at this. So you can see we have quality of life at the center, but look at all the other things that are being measured: symptoms and side effects, social functioning, physical functioning, and psychological functioning. So this was one way of kind of conceptualizing how to measure this. And this was another way to kind of break these things down a little bit. But what I'm pointing out here is that symptom status was always part of what people were thinking about as quality of life. When we think about the pro-CTCAE now, which is kind of looking at toxicity from treatment, but is also looking at symptoms, people think that's a separate thing, but it is really a component of quality of life. And in this next slide, really, I want to point out that when you ask somebody overall, how is your quality of life or how are you feeling today? Thinking about walking down the corridor in the hospital or in near your clinic and saying, how are you today? You're kind of asking that global question, and the person that you're talking to might say, oh, yeah, everything's okay. But if you really started to ask them, their back is bothering them, they didn't sleep well last night, and they may have a variety of symptoms that really they're kind of putting together to give you that global assessment. And here, if we see patient A and patient B, we can see patient A has a decreased functional status, but if we look at patient B, it's pretty good. If we look at disease symptoms, there are a fair number in patient A that's low, but better in patient B over there. But again, just the point here is both of them have the same global assessment of quality of life. And you really do have to dig down and look at those domains to understand what people are experiencing and how they're evaluating that global rating. This is another model, again, from the 1990s from Wilson and Cleary, who really were not just doing this for cancer, but really overall looking at quality of life. And you can see on the left are the biological and physiological variables, but then symptoms are how things are manifested in the patient. And again, you can see cancer therapy coming in there, if you will, intruding and causing new symptoms for someone. And over at the right, I've circled non-medical factors, which again, we now talk about social determinants of health. And again, we're always part of these things, but we're now beginning to pay more attention. But if we look again, the patient comes to the illness with pre-existing conditions, and we very seldom actually pay attention to this. This is what I call host factors, the life experience. Did they have depression before? Did they have other chronic illnesses? And so this is the soil, if you will, in which our cancer treatment starts to cause problems or symptoms in patients. And again, there are the characteristics of the individual, part of that life history, their personality and other issues, and then their social support and environmental context. All of these things really need to be considered, but we seldom do that, except if we have the luxury of doing a very comprehensive study where we're asking a lot of questions of people. So now I want to start to show you a little bit of data from some of the clinical trials work that I've done over time, where I want to point out that symptoms really are influencing all these domains. And this is baseline data from the breast cancer prevention trial, which was conducted in the 1990s. I had the good fortune of being able to do the quality of life study for the BCPT, the P1 trial. But look, that symptoms here are all highly correlated with all of those domains on the left, whether it's pain or physical functioning, mental health. So really understanding the symptom profile of a patient may be very important to both improving their quality of life as well as understanding what they're experiencing. And those were all women before they ever started tamoxifen or a placebo. So these are midlife women. And here is some more data from that particular study where you can see by age, the dark blue are the women 35 to 49, the yellow are the women 50 to 59, and the aqua are the women over 60. And so I'm pointing out with the arrows here that women 50 to 59, not on any tamoxifen yet, but just in that perimenopausal, menopausal period of time, are having hot flashes, night sweats, vaginal dryness, and joint pains. And joint pains do grow up as women age, and we all know that. And if we think about aromatase inhibitor therapy that we're giving to women with breast cancer, you can see why joint pains become such a big problem. So this is just the importance of looking at these symptoms. And again, the host factor here being age influencing this and the context. This is also from the P2 trial, the STAR trial, where we compared tamoxifen to raloxifene in healthy women. And the first two panels, the SF36 mental and physical component, show you that there's complete overlap. And the women are actually very highly functional in terms of the scores. 50 is the average for the population. They're above. Volunteers for a clinical trial have higher psychosocial functioning, and their physical functioning declines a little bit, and their depression doesn't really change very much with the treatment. But again, I wanted to show you when we looked at the symptoms in the trial, we could in fact see that there were differences between raloxifene and tamoxifen. And on the panel here, if we look at vasomotor symptoms, we can see that women who were over age 60 had fewer vasomotor symptoms with either of the drugs than the women who were younger. And again, if we look at leg cramps, we can see there's a difference between the two drugs. So again, very valuable to be looking at symptom profiles, even when the global quality of life domains don't seem to be affected. And again, another trial, this was the B35 trial. Again, I've had a long-term collaboration with NSABP, NRG Oncology, but this was a trial looking at tamoxifen or aromatase inhibitor and anastrozole in women who had DCIS, so a very low-risk situation. But we can see, again, here for these curves, the physical component scores comparing the two drugs. There's no difference, but if we look at hot flashes, vasomotor symptoms, tamoxifen has a worse profile, more symptoms in these women, and musculoskeletal pain, again, no surprise, is higher with the anastrozole. So we can see these patterns. And why is this important? Well, then we can talk to our patients about this. This is information that we can share in the clinic. So I want to talk about some early parallel research going on in my own laboratory. I was very fortunate because early in my career, UCLA had a cancer control PO1, and I was invited actually, this was in 1983, to put in a project. And this was my first foray in beginning to look at the impact of patients' experience from treatment. And I hope to recruit newly diagnosed breast and colorectal cancer patients. And just to say, at that time in the early 80s, already breast cancer treatment was sort of organized. So you could go to a breast clinic or a surgeon's practice and be able to get those patients. But the colorectal cancer patients in Los Angeles were treated all over. People, if they had had their gallbladder surgery before, they went to the same surgeon for their colon cancer that they had their gallbladder surgery with, and so forth. So it was very hard to recruit those patients. And be that as it may, it wound up mostly we were able to get breast cancer patients. And then I became an expert, if you will, in following these activities and outcomes. And we, in fact, followed patients for the first year after their treatment with breast cancer surgery, and did a randomized trial, which was a failed trial. I could tell you about that, but we had a lot of good descriptive data about the experience of women with that. And because we had followed these women for a year, I realized that some things were getting better. Physical functioning was getting better, but the psychosocial function didn't recover, and sexual function was terrible. So I was able to get some funding from the American Cancer Society to follow this cohort further, and I was able to follow them for 2 or 3 years later, and that achieved some new information, particularly about sexual health. And then when there was an RFA from the NCI in the early 90s, I was able to get an R01 to look at sexuality and intimacy in breast cancer survivors. And I did this study with Julia Rowland in Washington, where she was at Georgetown before she became director of the Office of Cancer Survivorship. And we focused particularly on women who were about a year out after treatment, did a couple of very large studies in terms of cross-sectional data and recruited them for an interventional study, and tried to also focus on African-American women. Again, because I was beginning to see all these symptoms in our patients who we were doing in our following in our research, I noticed, again, managing menopausal symptoms was really problematic. And I was able to get funding from the Department of Defense, which was newly organized at that time. This was, again, a failed grant application to the NIH, where mostly the male reviewers said, oh, those are not problems for women with cancer. But finally, the DoD actually appreciated the fact these were issues. And then again, I was able to get a core grant supplement to look at the issues in younger women with breast cancer. And this is when I first began to look at these issues, not only in terms of bone health, cardiovascular health, but beginning some of the work on cognitive function in women after breast cancer treatment, focusing on these issues in younger women in particular. So what did I learn from these studies? Well, again, I've already mentioned the host factors. What the patient brings to their cancer diagnosis is very important. And if you could just think, if you're a clinician and you're seeing a patient, and if you could just ask the patient, have you ever had an episode of depression in your past life? Okay, that's one question that would be very valuable, because we know that people who have had a past episode of depression are more likely to have another episode, and the, if you will, the trauma and the difficulties of having a cancer diagnosis and treatment are going to potentially precipitate a recurrence of that. But again, many things we don't ask about. We focus on the tumor and we focus on the characteristics of the tumor and whether maybe somebody can tolerate that treatment, but we don't really know what someone has experienced before, which may influence all of the symptoms after their treatment. Again, the importance of collaborative team science. I have had the good fortune to work with many social scientists, particularly psychologists, some psychiatrists, since the beginning. That first grant that I had was with a psychologist and a psychiatrist. And so very valuable to be able to do that because I had no methodological training. When I mentor people today, I say, you need to get that master's degree, you need to get that PhD, whatever it is, you need to learn that science because we do not learn that in medicine. And again, I've had a lot of basic and translational collaborators as well. And then the next message here is to never do a survey or an intervention without either collecting clinical data or biological specimens. And again, if we need to move the translational needle on this kind of research, we need to look comprehensively. So it's not just enough to do that survey. And then the value, as I've already indicated, about building on past observations and findings, especially when they complement the clinical experience. And again, because I'm a clinician, I have been able to move back and forth from the clinic when I begin to hear about new symptoms or problems a patient has, that then becomes a point of investigation. But also, if I'm investigating something or doing research or trying to manage those symptoms in a new trial, I can recruit those patients. I can also do what I learn in the clinic from the studies that we've done. So again, the importance of my parallel medical oncology practice, just as I was alluding to, again, I was, again, in the very beginning, taking care of patients at the VA with very advanced cancer, running a palliative care and rehabilitation ward. But again, because of the focus of my research and my move back to UCLA full-time, my practice is really focused on breast cancer patients. And then in the 1990s, with the emergence of high-dose chemotherapy treatment, which we all know was a failed experiment, unfortunately, but it did lead to a lot of toxicity, and we were able to observe that, unfortunately. And fatigue, cognitive difficulties, and menopausal symptoms really kind of became preeminent in managing the after effects from these treatments, as well as the more widespread use of chemotherapy. And again, having lived through all of these decades of changes in treatment of breast cancer, I can say, there's great enthusiasm around the turn of the last century, this last century, to give everybody chemotherapy. And if you had a tumor that was larger than a centimeter in size, you got chemotherapy. And that meant a lot of early stage breast cancer patients were being exposed. And so there was a big pool of people now who were getting chemotherapy. And before the anthracyclines were popularized, CMF was very popular. That caused probably more cognitive difficulties than we see with some of the other regimens. And so I was beginning to see more people in my practice who were having these kinds of persistent symptoms. And that's really when I embarked on what I would say the last 2 decades of work, which has really been focusing primarily on fatigue and cognitive function. And I think the good message here is that with the advent of genomic tests for breast cancer in particular, but other tumors, we can be much more specific in who gets the exposure to chemotherapy and who does not need it anymore, which again is really very important for us in minimizing the morbidity of cancer treatments. So just to point out now, in terms of talking about survivors, it's really wonderful for us to see so many people surviving cancer. Again, 18 million, probably more today, but this is some data that we have. And again, just to point out, this is about 5% of the US population. Okay, so there's nothing to, be surprised about, if you will. It's a number of people that we need to be very concerned about. And thinking about who's surviving and how long, you can see here data from the National Cancer Institute that there are a large number of people who are living 15, 20, 30 years out. Women have slightly greater survival than men because of the kinds of tumors that they have, but we can expect this to increase even further because of the aging of the population, the screening tests that we have, early diagnosis for many different kinds of cancer. So how did we make these kinds of strides? Well, again, earlier detection, new drugs and other treatments, the advent of combined modality therapy, prolonged adjuvant and or maintenance therapies have really played a role. And again, in the case of breast cancer, because of our endocrine therapies, we see many fewer second cancers, breast cancers, than we used to see. But think about all the patients who are living now long-term on immunotherapy with melanoma and other cancers. So there's, again, a lot of therapy that patients are getting that are leading to longer lives and survival. And then this prevention of second malignancies. But there is a cost, and the cost is time. And if we think about it, when I started my career, patients, say with breast cancer, just had surgery, maybe they had radiation, they were in the hospital for a longer time with that initial treatment. They might have had a radical or a modified radical mastectomy, but it was kind of over with it, 6, 8 weeks after their initial diagnosis. If you take a breast cancer patient today, it may be 9 months to a year before she finishes any treatment. If she has reconstruction and even has more prolonged targeted therapy, it may even go into 2 years. So a very long period of time, and that period of time really is kind of mirrored in the time of recovery. I did the quality of life recently for the Olympia trial, which was just after adjuvant chemotherapy and BRCA1 and 2 carriers, a PARP inhibitor for a year. And we expected that there would be recovery in the control arm that didn't get the PARP inhibitor by a year, because that's what we had seen in a lot of other trials. But no, even in the control arm, it was 2 years before fatigue improved in those patients. So the burden of our initial treatments now are much more substantial. So then really for many patients, cancer is now a chronic disease. It just, may be chronic in the sense of you are getting ongoing therapy, and I'll speak to people living with metastatic disease, but the sequelae and the after effects may not go away for a large number of people. And again, this is what we've been focused on studying in the last couple of decades. So just to kind of clarify some semantics, if you will, in general, we think about a long-term effect as something that comes on during treatment. So it could be fatigue, it could be cognitive difficulties, it could be mood changes, whatever, difficulties with sleep, and it just doesn't go away. You're seeing that person back. Normally, we expect people to have a recovery in the year after their treatment ends, but if it's persisting beyond that, it's really a long-term persistent problem that came on associated with the treatment. In contrast, a late effect is something that crops up later, kind of out of the blue. So the patient who goes into heart failure later, or the patient who may have osteoporosis and that starts to have fractures later, things that really are not there that are immediate with the treatment. They tend to be rarer, but sometimes more serious and catch patients and doctors by surprise. But again, it's difficult sometimes to kind of separate these things. And I don't really care if you call it a late effect or a long-term problem. They're just the after effects of the cancer treatment. So this is actually a Yale publication from Michaela's group, which I'm a consultant on her ACS grant, and this was some work that she and her team were doing, and they were looking at the NHIS data set, the National Health Interview Survey, and they were looking at what happened to patients in terms of self-reporting about whether they have limitations, and if this is you can push or pull an object or do kind of heavy lifting, things around the house, these kind of functional limitations. And this is looking at the people who said they had a history of a cancer diagnosis. And we can see over time the numbers who are without limitation, maybe it's going up a little bit, but look at this between 1999 and 2017. And again, these are cross-sectional, it's not longitudinal, but we can see the instantaneous reporting of people here now in 2017. We have 8 million of them roughly estimated from the population who are living with limitations from their cancer. Associated with their cancer diagnosis. And here, if we look at, again, this is the fold, this is a twofold, 2.25-fold increase in amount of limitations that individuals with a cancer diagnosis and history of cancer are reporting. So this is in fact quantifying some of those things that I've told you that you can either hear about in your clinic or hear about in the reports that we write about in terms of clinical trial results or in terms of observational studies. So again, to show a little bit about what goes on in terms of how we look at the results of a clinical trial. This was an NSABP trial, the B30 trial, which was a 3-arm randomized controlled trial in higher risk breast cancer patients. They had more advanced stage disease, and it was asking whether you needed to have a whole, an extended sequential course of docetaxel, which is a taxane therapy, in addition to adriamycin and Cytoxan. But one of the arms actually eliminated the Cytoxan. So there was a possibility that in some women, there might not be so much amenorrhea as a result of the treatment, and you might be able to have potentially a better outcome in terms of potentially having children or other effects. And so there's a difference in the docetaxel arms between these 3 treatments. But if you can see the results of the trial, these curves are pretty much overlapping, but the sequential therapy actually comes out to be a little bit better. You can see that it's better. And if you ask the patient and you ask the doctors, everybody's thinking that we have to have the sequential therapy. And if you look at how the data are reported in the New England Journal report, these are only grade 3 and 4, 3 and 4 adverse events. You can see the sequential therapy, which has 6 cycles of the docetaxel. You can see there's more neutropenia, there's more fatigue, in terms of these kinds of problems. Neuropathy wasn't even mentioned here because it's not grade 3 or 4, it's probably grade 1 or 2. But if you treat anyone with a taxane regimen, you know that neuropathy is going to be a big problem for these patients, and that's going to be a burden for them. This was our companion quality of life study for this particular trial, and we were interested in whether there was a difference in amenorrhea between the 2 arms. But I just want to point out the quality of life data. And these are data with the FACT Trial Outcome Index, which is the physical and functioning scales of the FACT and the symptom scale. And you can see that this blue line here is the sequential therapy. So here, 6 months of therapy is longer for these patients, but we have the other 2 arms kind of recovering, and everybody comes back to where they were at baseline. So if you look at overall quality of life and functioning, patients are actually doing okay. There's not much difference between the arms. But again, if we look here now at symptoms, which was a summary of a symptom checklist, look, there's a score of about 10 for the severity of and number of symptoms here at the beginning, and it's higher in the docetaxel arm where it's sequential, and they all come back down, but they're much higher than the patients were before. So this is this persistence of symptoms that we're showing in a clinical trial. And again, the clinical trial is great because you can compare arms, but you also have good data out to this point in time in a prospective way. So we decided to go back and look at neuropathy since that really hadn't been reported in the study. And again, looking here at baseline, patients are reporting a little bit of, this is either not at all, 0, 1, a little bit, 2, somewhat, 3, quite a bit, and 4 on the severity scale. And so there's not much neuropathy at the beginning, but some people do have some. But again, the sequential arm has a lot more neuropathy here in terms of patient-reported complaints. And if we look at everyone, they're still elevated out here at 24 months, again, a bit higher in the sequential arm, which has a higher dose. And then we went and looked at what were the predictors of having persistent symptoms over time. And this was what we were seeing in terms of whether you had baseline neuropathy, those few patients who did have neuropathy at the beginning, again, asking about what people are functioning like. The treatment regimen, again, more taxane, as you would predict. Being older was also highly significant in terms of the multivariate model, greater nodal involvement, mastectomy, and greater BMI. So these are all what we call host factors that influence the persistence of neuropathy. So it's not just getting that sequential longer dose, higher dose, but also these host factors. And again, very important. So again, we did some qualitative data with both patients and doctors to see, would you ever modify your regimen based on these things? Patient said, no, I want the best therapy. If it's better, I want it. And the doctor said, well, I couldn't do anything that was off guideline. If the guideline says this, and these were good oncologists, both in the community and breast specialists at various institutions. So that was an interesting exercise. And again, just to show you here that the severity of the neuropathy actually influences the quality of life. So this is the FACT-B trial outcome index, the quality of life measure, and we can see the higher the severity of the neuropathy, the poorer the quality of life. Other people have done studies, again, showing that there's a higher fall risk in people who've had taxanes as part of their therapy. And so this becomes an ongoing problem that somebody needs to live with. And I don't even want to go there, but if we think about immunotherapy in patients who become adrenally insufficient or have bad thyroid complications, others from the immunotherapy, these are things that the person might be getting curative adjuvant therapy, but then has these sequelae that we have to deal with. So we very much need to be concerned about these things. So this is a way of now looking at what we're doing to patients in terms of the long-term biological effects of the treatments that we provide. And a lot of the work that our group has been focused on has also been accelerated aging. This is a nice review paper that Mina Cedric wrote several years ago. He's now been recruited to UCLA and is part of our group. But again, thinking about the fact that we are exposing people to all of these kinds of therapies, and it's great for the cancer cells, but it's not so great for the normal tissues in terms of the injury that we provide to those tissues. And if you want, you can think about them as off-target experiences. And these all lead to increased inflammation in the body and the potential for accelerated aging. And so we need to think about a subgroup of patients who may have these long-term problems. Now, the most classical subgroup for thinking about this are the childhood cancer survivors, who we now have 30, 40, 50 years of follow-up showing that they are all dying at an earlier age. They have comorbidities that you would expect with much older patients and have the frailty phenotype where people have fatigue, difficulty doing physical activities, and so forth, and are impaired as a result of this. And in cancer, when we were only treating people in our 60s, 70s, and 80s, where they might not live long enough to have these kinds of problems, some of us who've been interested in younger adults with cancer are very worried because they have no other risk factors other than the cancer. We're treating them intensively, and we are beginning to see accelerated aging in these individuals who are now living a longer time with the after effects. So we really need to be thinking about cure, but we need to be cognizant of the potential long-term and late effects that may be occurring. And it would be wonderful if we could really figure out who's most susceptible, so we could, in fact, personalize this and do this more precisely. So the chronic symptoms that I've told you about in adult cancer survivors, such as fatigue, cognitive difficulties, neuropathy, pain, decreased physical functioning, insomnia, these are all classically things that are very common in aging. And if any of you have had aging parents or know of individuals who you've watched go through this, you know that the frailty phenotype as people go, unless they die suddenly as an older person, but usually there's a gradual decline in function. And we are seeing this now in patients who are much younger who've been treated for cancer with these symptoms as being part of the manifestation. So I've been very fortunate. About 25 years ago, Dr. Julie Bauer came into my lab as a postdoctoral fellow, and Dr. Mike Irwin, who's a psychiatrist, relocated to Los Angeles from the UC San Diego and to be the director of the Cousin Psychoneuroimmunology Center. And he really had been very innovative with other people, looking in the laboratory with better ways to look at inflammation. And again, if we think about the advances that have been made in measuring all sorts of things, he brought that science to UCLA and our ability to look at this. And this review paper that was written in JCO in 2008 with other colleagues really focused on the fact that the tumor, the metastases, chemotherapy, all of the things that we did to patients here on the left, that the patient came to us with and we did to them on the left-hand side, had a dramatic effect on the neuroendocrine system, really through inflammation primarily and interfering with sleep and having all sorts of effects on the central nervous system, leading to the behavioral alterations that you see on the right, such as depression, fatigue, impaired sleep, and cognitive dysfunction. And again, this gave us the biological underpinnings, if you will, for understanding some of these symptoms. So again, I was very, very fortunate. And our group has really looked at all of these symptoms in a variety of studies. So just again, for those of you who may not see patients who are complaining of this in the clinic, to tell you what a patient describes to us. This was actually a physical rehabilitation physician with breast cancer who said, During cancer therapy, I also always felt the exhaustion of physical exercise without any of the positive physical attributes. My limbs felt heavy. The quality of my sleep was changed. The mere act of sleeping itself seemed like work sometimes. My brain felt tired, and so did my spirits. I seemed to have lost my zest for life. So I think, this really encapsulates all of those symptoms. And when I used to see these patients initially, in fact, one of my colleagues who was diagnosed with breast cancer and had these symptoms, they look depressed. And just kind of say, why don't you get on with your life? What's going? But they're really suffering and symptomatic. And now that we've all lived through COVID and long COVID, this is what's going on in long COVID. And my, again, interpretation of what we see with the inflammation associated with COVID is that the body only has a certain repertoire of how to respond to an acute inflammatory challenge. And that's what we do with cancer treatment, whether it's radiation, chemotherapy, putting all of these things together, we're dealing with an acute inflammatory challenge. And again, this is how the body responds with an increase in pro-inflammatory cytokines. And there may be local and systemic effects, including all of these cytokines affecting the central nervous system, where in fact you can see both the brain symptoms and the fatigue really being influenced by inflammation. And we've been able to document this in quite a bit of our work. One of the first studies was that Dr. Bauer actually followed up on the patients that we had recruited in our sexuality and intimacy study. We had a couple thousand patients where we had all these kinds of questions asked about them before we went into an intervention. And she was able to recruit some of these patients to come back into the lab and actually test them and evaluate them and actually show that there were changes with inflammation and bringing that into our lab. But things that are associated with fatigue in our cancer survivors and breast cancer survivors are the comorbid medical conditions. So again, things that are also going on in the host. Increased body mass index, anemia is very rare, but demographic factors, younger age, lower income, not being married or living with someone is important. Psychological factors, a past history of depression, a catastrophizing coping style, but good things being physical activity, so inactivity not being good. And then these comorbid symptoms that were often co-occurring with fatigue, such as pain, menopausal symptoms, and sleep disturbance. A lot of these things all associated with inflammation. And in the early studies that she did, she was able to document higher levels of inflammation in the patients who were more fatigued. And this was going out 5 years and then subsequently 8 years out after their initial questionnaire data. And again, in many works that she's written, and again, this is one review a number of years ago, really looking at host factors that are associated with this and ways that we might begin to intervene on this. And Dr. Bauer actually led the ASCO guideline fatigue a guideline on fatigue in 2013, and we just updated it now where she again led this as well. So if you're interested, you can read about the recommendations, how we manage fatigue in cancer survivors. But I just want to show you about how we might be able to get a little bit more precise in terms of understanding why some individuals might be more predisposed to have pre-existing fatigue. This was in a study, it was our mind-body study where we recruited women who were just about to initiate endocrine therapy, and we were following them for cognitive difficulties over time. But this was from the baseline data where we looked at fatigue and cognitive complaints in these patients and looked at SNPs in the promoter regions of TNF, alpha, IL-6, and IL-1 to see if there was any genetic predisposition to have a greater inflammatory response and symptoms. And here what we're showing is with the MFSI fatigue score, patients with the GG genotype of TNF 308 have a higher reporting of fatigue. You can see the AA SNP has a very low reporting. Here, if we look here at IL-6, the SNP, the GG pattern has a higher reporting of fatigue. And here, this is the CC SNP of IL-1. So you can see that there's variation based on the genetic components in a person's makeup. These are not abnormalities. It's just how they might be handling potentially inflammation in their body. And this was true for both cognitive complaints and fatigue at baseline. In addition, we put together an additive genetic score. So the more of these SNPs that you have that are the higher burden SNPs in terms of inflammation, the greater the reporting of fatigue you can see in terms of the score. And in a multivariate model, predictors of fatigue were age, body mass index, whether you got chemotherapy or not, or the genetic risk score. So again, these host factors that may be giving us a clue as to who may be more at risk for symptoms, and if we could in fact use this. Now, I have to say, we haven't completely validated this. We have a new study actually where we're one of the clinical trials that we're looking at, maybe even Biosh's 1418 trial that he was just asking me about analyzing, where we may be able to replicate this data. So Dr. Bauer recently did another study where we wanted to understand how did people, all of our other data had been cross-sectional. How did they get there? Did they have fatigue in the very beginning, or did it sometime come off on with treatment? And so this was an inception cohort of patients who had not yet gotten their chemotherapy treatment. They had had surgery, but had not had radiation. And if we look here, we can look at the baseline, which is over here on the left, and you can see a few of the people here. This is a cohort of a little over 200 patients. A few of them had high levels of fatigue on the MFSI, but most of them here in the green had stable low. 178 out of these 270 patients had low scores, and they never actually rose. But if we look at 18 months over here, which is where we might do a cross-sectional analysis of patients. So these are people who have somewhat elevated levels, and you can see some of them were actually low to begin with. Some of them were high and actually declined and even didn't have high levels, and then some who were persistently high. So understanding, again, we've done a lot of analysis of this data, but there are a number of psychosocial predictors, and I was mentioning to someone last night, early childhood trauma is actually a predictor in some of these individuals for having high levels of fatigue and other symptoms at baseline that actually persist. So that could be something we might want to be able to incorporate into our evaluation. So why is it important to understand biological mechanisms of the treatment? I can't tell you how validating this is for patients. People look me up on the web or they've heard me talk, et cetera. And when I can say to them, there's a biological reason why you're still having fatigue or cognitive complaints, they feel much better. It doesn't take away the symptoms, but it means that they really have something. It's not just in your head, literally and figuratively. And so that's very valuable. In addition, it really helps us to develop interventions, either pharmacological or behavioral. And we've now done a lot of behavioral interventions where we actually show we can move the needle on the inflammation, and it is actually associated with the response, the clinical response to treating those symptoms. And possibly we might be able to identify people who are at higher risk. And there may be some concerns about how this inflammation is also affecting tumor biology and prognosis for patients. So there's a lot going on here, but understanding this, I think, is very powerful. So this is a review that we wrote recently that talked about some of these things. And if you're interested, you may want to look at this, but it's incorporating these issues of accelerated aging, persistent inflammation, and looking at interventions, behavioral and potentially pharmacologic, that might be useful. And I'm just completed a phase 2 trial of a very interesting nutraceutical that seems to be actually very effective in decreasing cognitive complaints in women with breast cancer. And we're actually now going back to the clinic and doing a mouse model to see if we can actually show the biology of how I think we're decreasing neuroinflammation. So these are very important things to really understand to improve the well-being of our patients. I want to just spend the last few minutes talking about a couple of special populations that we need to think about, and for future research, people who are now in this field to think about, and that's the young adult cancer patients and survivors and people living with metastatic disease. So again, this is a minority group, if you will, within the 2 million cancer cases that are diagnosed every year, but very important. And it's again challenging because young adults have heterogeneous cancer diagnoses. It ranges from leukemia, people who are getting transplanted in the hospital, to brain tumors, to, again, thyroid cancer. So lots of different kinds of cancers. They're often diagnosed late because people don't think about cancer in a young person. Plus, we don't screen for cancer. Again, we've just now moved the colorectal cancer screening guidelines down to 45, but a lot of them are being diagnosed when they're 35. The breast cancer patients are being diagnosed. They come in with a lump, nobody pays attention to it, or it's post-pregnancy that they may have this. And so again, there's a good reason why they often have more advanced disease. They get more toxic therapy, mostly because we've thought that they can tolerate it and we want to treat them for cure. So that's very important. A lot of them are uninsured, so that's a big issue. It's their first encounter with the healthcare system. And so the financial toxicity is very, very high. And already this segment of the population has high rates of anxiety and depression just in the background before they ever get cancer, and is exacerbated with this. So again, very disruptive to young people. And it's not the same for a 20-year-old as it is for a 35 or a 45-year-old. So again, there are different age and developmental stages in this group that we have to pay attention to. But I want to call your attention to this particular study that was commissioned by Teen Cancer America, really looking at the cost of cancer care, and not just the economic costs, the financial costs, but also the lost employment and opportunities, other things that happen to them, loss of well-being. And again, it's a dense slide, but I want to just pull out here the age 35 to 39 and look at, this is men here, and this is women, and this is the total in millions in terms of cost. And there's this big difference here, and this is probably driven by the breast cancer cases, where, again, very common disease in this age group, but for women having more burden here. And then if we look at, I want to just say the health system costs here, the cost per person per thousand is 35,000 if we just look at the health system costs, but the productivity costs are 199 per person. But if we look at the total financial costs overall, it's 259,000 per person. And again, in terms of burden of disease, in terms of the non-financial, over $1 million. So again, this is looking at a lifetime perspective. So we do need to pay attention to these younger adults with cancer. And then finally, coming to the people living with metastatic disease. This is a very large and growing number in our clinics. We are very fortunate now to have had targeted therapies and serial targeted therapies or immunotherapies that have been very effective. And it's very valuable to be able to take care of these patients, but they never go off therapy. It's very costly for them. There may be chronic morbidities. And again, chronic myelogenous leukemia, which was kind of the poster child for this group of patients, very important. They do have chronic fatigue as an issue. It could be a burden in terms of their being adherent. And so finding ways either to take them off their therapy, people are looking at minimal residual disease, a lot of other things, as well as mitigating these toxicities. So very important for us to think about them. And there was a good study done a few years ago by folks at the NCI calling out, in this case, bladder, breast, colon, and rectum, lung, and lung cancer, melanoma, and prostate. So here's lung, and looking at the number of people living with lung cancer that have metastatic disease. You can see the large numbers here, and recurrence as well. The dark blue is recurrent, and de novo is the light blue. And you can see again for breast, we have a lot of recurrence, but we also have de novo going on here. So these are important diseases that we need to pay attention to because people are on long-term therapy. And if you look at the length of time, the green boxes here are out to 10 years. So this is the prostate cancer patients, melanoma, greater than 10 years, colon and rectum, and so forth. So these individuals are living a long time on chronic therapies very often. And so the financial burden and the morbidity from therapies need to be we need to think about. And this is a very hot and new area for people who want to work in survivorship research. So I'll just close in the last few minutes about how we might think about survivorship research and survivorship care. And this is from the Institute of Medicine Lost in Transition report. And it may not be a perfect diagram of what goes on, but often we're treating people out here for cure. And this is the group of people who are living a long time. And this is where we can focus our attention in terms of research. So again, in terms of research, we can think about developing and evaluating treatments to improve quality of life or quality of care. We need to focus on preventing the late effects, as I've already talked about, and we need to attend to the vulnerable populations and those with comorbid and conditions and who are disadvantaged. And we've spent a lot of time in the last few years about talking about the integration of palliative care with metastatic disease from the time of diagnosis because of the benefits. But palliative care is something that we actually need to do in every cancer patient and every survivor, because really symptom management, as I've tried to emphasize, is very powerful. If you can control those symptoms, patients are going to have higher levels of function and they're going to be able to do better over the long haul. So thinking about palliative care again for everyone who's treated with cancer, and particularly for survivors, is very important. This is a nice diagram from folks at MD Anderson, really kind of thinking about the continuum of care. And we can call it palliative care, we can call it supportive care, but all of those things that we give to people at the end of life, we should be giving right from the very beginning, and really trying to highlight those most in need by screening, if you will, for symptoms and morbidities that people are having. So in thinking about the kinds of study designs you might want to consider in your symptom science research, again, randomized controlled trials are really important in terms of evaluating treatments. And I've been very fortunate because of my work in the cooperative groups, but also even in our own studies where we've either done attention control, wait list control, or placebos, where you can kind of catch the natural history of the condition and then look at your intervention. But observational studies are also very powerful, and you can do a lot more data collection sometimes in your observational research, particularly collecting the data, the biological specimens, and more enriched questionnaires. Intervention studies are also very, very powerful, because if you see an effect from your intervention, and it can also show a biological marker moves with that, that again validates that. All the things that we would think about in terms of a therapeutic trial, we want to do with these kinds of interventions. And then doing correlative studies, as I've mentioned, looking at animal models, if we can use them to actually understand the mechanisms by which either drugs work or how the symptoms occur. Some additional observations, well, again, clinical trials that include symptom assessments can identify target symptoms in need of our attention that we might not know about. We need to understand the treatment emergent as well as persistent post-treatment symptoms. And we need to have effective management for symptoms in addressing adherence. Again, increasingly, we know that patients who have more symptoms, who have more social determinants of health difficulties, are likely to be non-adherent to their therapy, which could be life-saving. And again, looking at research which focuses who's at greatest risk would be the most efficient way to do this. So defining those populations, developing precision symptom management would be very valuable. And understanding the biology, again, as I've emphasized, again, the good fortune I've had to have good collaborators to do this is very powerful. So what are some of the challenges and opportunities? Well, funding sources for symptom-related research are limited, and assembling a multidisciplinary team might be difficult. Again, in a cancer center like yours or mine, this is a lot easier to do, and certainly being on a university campus is very helpful. And again, comprehensive assessments that I've had the real privilege of doing over my career can be very daunting. So it may not be easy to do this. But the growing number of cancer survivors really tells us that we cannot ignore this anymore. And it's really, just as we're trying to figure out what's going on with COVID, with millions of people now having long COVID, we have 18 million cancer survivors. We need to be doing this for our cancer survivors as well. And lastly, I wanted to show this nice editorial that some of our colleagues in France who've been studying the Canto cohort, it's a cohort of breast cancer patients, about 10,000. Really, they are now also, again, we've collaborated with them, but they're really looking at systemic inflammation and cancer-related frailty to kind of look at how we might put this into our clinics in the future with precision identification of those at risk and need of treatment. So in closing, I want to express my appreciation to everyone who's helped me along the way. This is not a solo act. I've had wonderful collaborators as well as patients who've been very, very important. Also the funding that I've had over my career. And I want to thank you, and I'll be happy to take some questions. Yes, Dr. Sam.
So inspiring. You can grab the microphone. So you have this wonderful experience and advantage in your view, looking ahead 10 years, things are better for our patients. What are the main things that have happened to make that come true? Do you think it's de-escalation or earlier interventions or better post-treatment interventions for those types of symptoms?
Oh, maybe we could get the lights back. So,
This is the
so-
dramatic portion of our morning.
So, I think if changing anything, taking away something is very, very hard. Right now, we have a few de-escalation trials in NRG oncology in breast cancer. And, we've perhaps in prostate cancer with active surveillance are reducing the treatments that patients would get treatment with. But it's so hard to sell this. And it's really hard in the medical community where it's hard not to treat. And it's also hard for patients, and particularly with our minority underserved populations where they feel that the health system has cheated them and hasn't helped them, in the past. And if we're trying to kind of say, well, your tumor is so favorable that you really don't need this, it's a hard sell for things. And because again, the American psyche, I don't know whether they can probably do it better in Europe and a lot of countries, but our psyche is to treat. And even when you think about the troubles we had with managed care healthcare, people feel that they're being denied something in our system. And so it's very, very tough. I don't know if we can change our culture. I think that's the big challenge.
So, Patty, this is a somewhat provocative question that I've been thinking about after I read an article in the New England Journal of Medicine, I think last year, and it was titled "A Nocebo Effect." And I just wonder if some of this is related to the way we describe these drugs as horribly toxic, and people really look for the side effects. And
Yeah.
many of the things that patients describe, unfortunately, I experience as I get older,
Yeah.
the like cramps, the back pain, and so forth. And
Yeah.
I attribute it to my age because I don't take any
Yeah.
drugs. But
So it's
but
an
when you take the
excellent
drug,
question.
you attribute it
Yeah,
to it.
let me tell you about an interesting story. So I have I'm part of a UO1, which is looking at tolerability as with a moonshot grant. We're in the last few months of it. And we are going back and looking at the P1 data, the BCPT, where again, I showed you the data in the healthy women before they ever started anything. And we're, Lynn Henry and we got additional, using some of our BCRF money to look at the SNPs at rapid metabolizers of CYP2D6 to see if more toxicity is actually occurring in this particular trial. But we've begun to look at the tamoxifen versus placebo arm with the statisticians we've been working with. And when we looked at discontinuation of therapy in the randomized trial, again, placebo versus tamoxifen, we actually found that there was actually seemed to be no difference when we kind of looked at overall toxicity. And then as we began to explore things, I'm just looking at the nocebo effect in the control arm. And what we see is in the patients who got placebo, they have an increase in their hot flashes at 3 months. It kind of stays steady at 6 months. It doesn't go up. In the treatment arm, it's higher. The odds ratio for hot flashes being elevated at 3 months is higher in the treatment arm with tamoxifen and goes up further. And it's particularly marked in the women who are less than 50 and 50 to 60, whereas in the placebo arm, it's in all age groups. So I'm going to write a paper on this nocebo effect because for me, this was fascinating to see that, in fact, I mean, tamoxifen had a bad rap. It was a cancer drug. Why you're giving a cancer drug to prevent cancer in, healthy women. But I think our placebo trials will have a chance to look at this issue. And I'm just, again, fascinated by the fact that we're seeing this.
Yeah, that's really interesting what you said, because we actually saw the same thing in a number of randomized trials, adjuvant trials in SWOG that we never published, that in the control arm, people who discontinue the placebo for whatever pill they were taking as in the active arm actually do worse in the control arm than those who don't discontinue the placebo.
And we're looking at some of these predictive factors. We're actually starting to do the longitudinal models, but absolutely. And when I just recently went to the literature to look at the nocebo effect in cancer, I couldn't find much. So I feel compelled to write this up because again, here's healthy women. They're not people with cancer. And of course, they're at an age group where they could have all of these symptoms together, but it's very, I had women when I was treating people on P1 who quit, when we divulged what treatment arm they were on, they were so upset that they were on placebo because they had attributed all of their sexual difficulties, whatever it was, to the fact that they were on tamoxifen, and they were very angry. It was very interesting. Yeah, yeah, yeah. So, but it's an excellent question.
Yeah, thanks, Patty, for a wonderful talk. I was struck by the number of lung cancer patients living with metastatic disease. It reminds me, maybe 25 years ago, or 23 years ago, Tara Parker Pope wrote an article, why curing your lung cancer might be the best thing, and the idea that people could live with these targeted therapies. And we just had the 20th anniversary of EGFR mutations, and we had a symposium here at Yale a few weeks ago. And probably very few people are cured on these targeted therapies, but they're living with them. And now, as we're moving to earlier disease, it's important to keep them on the drugs. So my question is about access and how, with the entire country or world, how do we get patients the right symptom relief? Can we use telehealth? I'm frustrated we can't even do telehealth anymore from here, across state lines. Are there processes in place where people could get both symptom relief and support, and they also need emotional support? And how are we going to get all diverse populations this access?
Yeah, I think that is the next question. When I was at ASCO, I was impressed in the sessions that I went to where people are now trying to incorporate pros into monitoring of patients. There are major challenges in trying to be able to deliver this, and whether it's going to be navigators or telehealth, I think this is the next group of interventions that we need to test and show they're cost effective as well as effective in terms of benefit for patients. And we need to be able to do that outreach. And absolutely, and for some things, we don't have a lot of symptoms. I mean, I can tell you a range of things you can do for fatigue that are non-drug related. Tai Chi is very effective for insomnia. When I speak to communities, it's very hard to get CBTI for insomnia. It's probably not even easy here in your cancer center to get that, but Tai Chi is effective, acupuncture is effective, and in many communities, these are available. But our community of physicians doesn't actually know a lot about these behavioral interventions, and that's why the ASCO guidelines are very powerful. If you look at the ASCO fatigue guideline, exercise is very important. Mindfulness is very effective. Cognitive behavioral therapy, there are a whole bunch of therapies that, again, are not costly in terms of, how we think about the cost of our drugs, but you need to be able to connect people. And a lot of these things are now available online. So it's kind of cataloging them and connecting patients. But I think we need to do high-level randomized trials to show the evidence so that we can get payers to pay for these things. Because one of my sadnesses is that we all do these randomized trials, get NCI funding to show something's effective, but they're not disseminated. Ann Partridge, Antonio Wolf, and I did, and Julie Bauer did a study on mindfulness and survivor education in younger women with breast cancer. And we found that the mindfulness in particular was very effective. Very fortunate that we just got an R01 and we're putting it into an NRG trial to be able to disseminate now mindfulness either with an app or on Zoom delivery across the country, hopefully to rural and underserved populations, as well as, the cancer center kind of people will come on.
You could add that like the lung map trial, like the pragmatic arm, and grab large amounts of data from that.
Yes. And I mean, I think if you have descriptions of what people are experiencing, then you have that catalog of list of issues, and then you link it up with resources that are available. And more, they can be on a centralized portal somewhere. When I was at VCU a couple of weeks ago, one of the people that I met with is looking at cognitive difficulties in brain tumor patients. She's completely recruiting all of her patients via the internet. So she's getting her brain tumor patients for her intervention studies across the whole country. She's somehow gotten the permissions to do this. And so I think we need to be much more innovative. And that's what COVID also taught us, is there are many more ways to reach people. And so we need to get out to that community of patients. Once you can tell me what their symptoms are, I used to be a lung cancer doctor when I was at the VA. That's like 40 years ago, but I still have roots there. And so I think, those things are possible, but we need to be able to know what people are suffering with and then interview them and talk to them about what they would like to have, what kind of services might be helpful to them.
Patty, thank you so much.
Thank you.